Well, thank you very much, and thank you for the opportunity to be here. It's a slight return to my roots because, as I say, I've actually spent about 20 years in the NHS, and I came in as a Northwest Region supplies trainee. So my first roles in the NHS included centralising the Bolton store from Bolton Hospital to the main warehouse, So I've considered that to be, when people say to me, so were you a graduate management trainee? I say, yeah, I was. I worked in supplies and procurement, and it's stood me in good stead ever since. And it's good to see so many people here, because I think that you are currently in the space within the NHS where the greatest challenges currently exist. We're all involved in the ongoing effort to maintain a safe, high-quality, cost-effective NHS under the greatest financial pressures that we have seen probably for a generation. And people struggle with the fact that three things can be simultaneously true in the NHS. It can be true that the NHS is the most efficient health system in the world. If we were to fund the NHS at the same funding level per head as, say, France, we would fund it another £15 billion a year. So we're driving a very efficient NHS. But it's also true that everywhere you go, you see the opportunity for efficiency improvement, you see unwarranted variation, you see waste, and those things we have to address. And it can also be true that in the context of a very efficient NHS and an NHS where you can see waste and the opportunity for improvement, it can also be true that the NHS needs more money. What I would say is that the campaign to drive a more efficient, more productive, more effective, fewer errors NHS is not the opposite side to an appropriate level of funding. It's what makes the taxpayer confident that if they choose to give the NHS more money, it will be spent well on more patients, more care, more health, and not spent on waste and things that they would choose not to fund. So we have an obligation to create an investable proposition, a NHS that the public is confident in and believes that it wants to fund to do more things. And I think the NHS's performance over the last few years in this financial circumstance have been pretty impressive. If you do the numbers, the statisticians say that the underlying financial pressure from a growing and ageing population is about 1.5% per year. So there's an underlying 1.5% cost pressure built into the system. If you add that to that, people's growing expectations and the impact of lifestyle diseases and the like, what we've seen is between a 3 and 4% real growth in demand on the NHS year on year for the last decade and going back longer than that. And in the last 7 years, what we've seen is 1% real funding growth. So if you do the maths, you say that the NHS has delivered between 2 and 3% productivity each year over the last 7 years. And on top of that has also been able to introduce new medicines, introduce new vaccines, put in new equipment, and all of those things have been absorbed. So I think the NHS has been doing really well on driving productivity. And when I read in the papers in the last couple of days that the productivity improvement of the services sector in the UK economy over the past quarter was 0.2%, I think the NHS can hold its head up proudly over what it's achieved and what it's been doing. But that doesn't mean that there isn't much more to do and that there isn't much more to gain. And it also doesn't mean that if we look forward, things aren't going to get harder. If we want to be able to maintain a national health service free at the point of use, if we want to be able to support thing which routinely is tagged as the single institution that makes people most proud to be British is the NHS, then we are going to have to be able to innovate, and we're going to need to be able to take that innovation and adopt it somewhere else, and we're going to need to be able to take innovation and adoption and turn it into general spread. How do you get from one place that's done brilliantly to the whole of the NHS is doing the same right stuff, and we've moved on to the next challenge. And the NHS has been historically poor at the spread of best practice. As was said, I spent a little while in the private sector, and in those 5 years, it struck me that I worked in an IT company, and I'd say that if one of our competitors brought out a new product which the market wanted, within 3 months we would have the equivalent product, and within 6 months we would be claiming to have thought of it first. If an NHS hospital comes up with a new innovation, the chances are that within 3 months everyone else will have declared it unsafe. So we need to move beyond that. When I was a hospital chief executive, I was hospital chief executive at the Royal Surrey in Guildford. When I went there, it was a very struggling hospital. It had the worst performing A&E department in the country. I took my A&E team to Guy's and St Thomas's, which at that time had the highest performing A&E department, and we copied their processes. I then took our bed management team to King's, which it's hard to imagine for those of you who know King's today, but at that time had the best bed management team in the country, and we copied their bed management processes. And a year later, we had the highest performing A&E department in the country, and none of it was an original thought. Our innovation was to go and find out what worked and deploy it. And so when I look across the GS1 pilots and the fantastic work that's been done across those 6, the impressive savings that are produced, the extent to which senior leadership buy-in has made those things happen, I guess my challenge is, so how does it spread? How does it go from stock management and materials management within an organisation to being the core of how you manage the flow of patients and you manage the flow of goods and services within that organisation? And how does it go from being locally great to being spread across the country, that it becomes the default? Because the NHS has to stop being great at one and done and start being great at the NN National Health Service. When we work it out, we deploy it nationally. There's always going to be a 20% change locally, but the question is, can you pick up the 80% and do it everywhere? And we have to do it in a context that's particularly challenging, that there's going to be very limited seed funding to do new innovations. We're going to have to be able to prove the return on investment. We're going to need to be able to deliver it fast enough for it to be able to pay for itself, and we're going to need to be able to get real payback, not hypothetical payback, so that boards who are looking at their cost pressures choose to invest and make changes rather than retrench and back off. And that's the challenge for the suppliers in the room here, is that this is not an easy market. You know it's not an easy market. We need to make it easy for people to make the right decisions. We need it easy, make it easy for us to be able to adopt those innovations into standard practice, and to make it simpler to do, to be able to copy and learn rather than invent for the first time. And part of that, I think, is moving on from where we are now to leveraging the real opportunities. We have other investments going on across the NHS, other innovations happening, and if we can bring them together to be greater than the sum of the parts, then we can get to scale. So I think about our global digital exemplars and our fast followers in the IT space. They are all being asked and required and given some funding to get to digitisation of their organisations, including digitisation of medicines management, the closed loop of medicines management. We know now from the evidence coming back out of the US that the single biggest payback on the deployment of IT in healthcare in the States following President Obama's investment has been in improved medicines management, reduction in errors, improvement in safety, and reduction in waste. We also have some evidence that suggests that the cost of waste and error in medicines management in the NHS is something like £1 billion a year. How do we tie the GS1 innovations into organisations that are moving into the space of managing medicines and bring them together as a single project so that you can have greater than the sum of the parts? We have hospitals across the country that are working with the Virginia Mason Institute in the States, I think maybe slightly self-proclaimed safest hospital in the world. But they have a lot of processes around getting it right first time, not making errors, learning from errors and moving around. I think the GS1 project fit well into that philosophy and that direction of travel. And indeed, some of the pilots for GS1 are also VMI pilots. So how are we tying those together? So it's not two projects going on under the same roof, but it's delivering scale. And I see across the NHS people investing in the technology to improve the flow of patients, investing in bed management technology, the tagging of patients, the tagging of beds, the moving around, understanding when someone's been discharged. It seems to me to be a pure fit with the GS1 technologies to bring this together, and let's do it right once. And if they're investing there, well, let's make that an investment in the deployment of standards, not an investment in the deployment of something that's unique to do one thing, and when we come back to do something else, we have to go through and rethink it. So our ability now to go from, we've proved it works in pilots, to how do we get it to scale, how do we get it across the NHS, and how do we start to think in terms of whole systems. One of the I think we have learnt over the last few months, maybe the last year or so, is that whilst there are opportunities for individual institutions to improve, some of the big wins are at the intersections between institutions, and we are moving through the sustainability and transformation programs, the STPs, through our accountable care systems, the ACSs, to say, if I really want to be able to transform the cost and quality of care for the people of this area, we need to move away from the competition between primary care, hospitals and community services and into we are one NHS and our job is to deliver on behalf of a population. And part of our diagnostic for that is if we look across the flow of patients through hospitals, we find patients in A&E departments who don't need to be in A&E departments, patients in GP surgeries who don't need to be in GP surgeries, and patients in hospital beds who don't need to be in hospital beds. But everybody is busy. So telling people in an A&E department that they need to go and see their GP, when the reason they went to the A&E department was they couldn't get an appointment with their GP, is a largely futile exercise. It's like one of those pictures where you're trying to make the Eiffel Tower by moving the little boxes around inside the shell. If we don't manage to do a channel shift, if we can't get people who are going to their GPs to talk to pharmacists or go online or talk to 111, we won't create the capacity that allows people in A&E departments to see a GP instead, which means we don't create the time in an A&E department to make better decisions over whether to admit or not, which means we don't manage to refer. This is a system challenge. This isn't an institution challenge. And as we move on to the deployment of standards like GS1, as we move on to what do these programs look like, we need to start thinking about the transformation of systems, health systems, systems for populations, not just the what do I do inside the local district general hospital, because that is whilst there is still clearly opportunities to find there is also a greater opportunity if we can look at the pathway and start putting the patient at the centre of our design rather than the institution at the centre of our design. So it is difficult out there. It's difficult to be a supplier selling into the NHS because there's not a whole lot of free money. It's difficult being a manager in the NHS, and it's challenging sometimes being a patient within the NHS. If we are going to continue to support the kind of NHS that the public wants and the public believes it has a right to, we are going to have to start confronting some of our traditional ways of working, a lot of our traditional ways of working, and taking a step forward. And maybe when we had a lot of money 10 years ago, we didn't completely grasp the opportunity that was there. Maybe it was too easy when there was money around to prop up old practices and old working ways. And maybe we should take the opportunity to take the advice of Rahm Emanuel, who is now the mayor of Chicago and was President Obama's chief of staff, who said a crisis is too good an opportunity to miss. Well, we've managed to create you a crisis in the NHS. I'd like to thank us for the opportunity that gives everybody. Let's work out how we work in partnership, how we leverage what other people are doing, and how we create that transformation. And thank you for your work.